Here's a presentation on Chapter 12, Client Education for Post-Operative Care. Or, we sure can be smart. Wish they would listen better. The objectives for the last chapter is to provide instructions to the owner describing the proper care of a patient after general anesthesia or surgery or dentals or whatever. Provide instructions to the client describing proper care of a patient with post-operative drains. Describe to the client education for post-operative care of a patient with a bandage, splint, or cast. Provide instructions to the owner describing proper care following surgical procedures for teeth extractions, GI surgeries, feeding tube placement, cystotomies, declaws, hematomas, lateral ear canal resection or ablations, orthopedic surgeries, cesarean sections. The list goes on ad infinitum. More and more, it is the technician's role, responsibility, duty to explain patient aftercare to clients. And that's a very practical thing because technicians know which restraint techniques work best. How to do this and not have somebody's face chewed off. What method is used to administer oral medications? What are the tricks of the trade? Which ones are okay in this case? Which ones are not okay in this case? The effectiveness of analgesic drugs. Okay, if you're sending home an NSAID versus tramadol versus buprenorphine or something, they need to know the pharmacological properties. You need to explain that to them. Things you always discuss with clients, and again, the given is that we have this written and we're going over written instructions. We are literally reading to the client. They will walk out with written instructions. They will have your verbal instructions based on the written instructions. You should have them sign the chart that they have received both verbal and written instructions for the aftercare of that patient, and that you should be able to refer back to what specifically those instructions were. That would include things like the timing of drug administration, any kind of wound care, daily walks or other exercise. Post-operative education before the procedure, that's when you start. When they call and say, I'd like to get my cat spayed, that's when you start perioperative education. And if they say, well, what's going to happen? We have some really good handouts. We have a great little handout on feline OHEs or spays. Stop by. We'll be happy to, give you one, or if you have a minute, we'll sit there and stand in front or take you into a nice little cozy room and we'll go through it with you. And if you decide to have Fluffy spayed with us, then here's what's going to happen and that kind of stuff. Do you have any questions? Any kind of instructions we should be written. Okay, don't ever say, do this or do that. It all needs to be written out. Discharge instructions should be explained verbally, going over. Okay, now here's the 5 rules. Fluffy cannot go chase dogs around the neighborhood, yada, yada, yada. And then all client questions should be answered. Ask non-leading questions. And obviously, the more open-ended, you can do that. And you'll be amazed some of the questions you get. I've literally had people say, well, okay, Fluffy's spayed, but will she come back and heat again? Or, is all the tomcats going to come back? Give them lots of chance, okay? We're doing 2 things. Number 1, we're taking care of Fluffy, so we know they'll know what to do. And number 2, we're building our practice. Trust. Communication and trust. General post-anesthesia instructions. There should be an instruction sheet for at least the first 24 hours, preferably longer than that, but at least that. Addressing confinement, feeding, medication, signs of possible adverse effects. If they have a problem, what do they do it when it's 2 a.m.? Some people, I know technicians that'll give out their cell phones. And really, they don't get that many calls, but boy, I tell you, talk about a practice builder. And there's nothing like the next day, the veterinarian's having a bad day and things aren't going well. At 10 o'clock, he gets a call and it's Ms. Smith, and she says, doctor, I last night it was 1:30 a.m. and I had a problem with Fluffy and I didn't know what to do, so I called your technician Bob, and Bob talked to me for about 10 minutes and he got me all settled and everything's good. I'm telling everybody in my neighborhood they need to come to you because you are just the nicest people. You talking about turning somebody's day around? You talk about sucking up for a raise? That's how you do it. You need other instructions, recovery crate. Where do you keep them? Don't just dump them in the backyard. Make sure, just because you're not exercising them mean that the 9 other Shih Tzus in the house aren't going to reward them to death. If they're on special diets, what it is, why it's a special diet. Medication, certainly we send a lot of medications home with patients. And in pharmacology, you need to know how to properly prepare and assess a medication to go home. You may not be the one to prepare it, but if somebody else does it, you need to check that label and make sure that it's proper, because when it goes home, they are now your problem. Okay, I know one of the quality practices I really admire. The people, they've hired registered pharmacy technicians to prepare all their prescriptions. Technicians, veterinarians, receptionists, kennel hands do not do prescriptions. Only registered pharmacy technicians do it. And their medicating errors have dropped to 0. Again, be able to identify timing, side effects twice a day doesn't mean 10 a.m. and 11 a.m. Be able to explain, and this ought to be one of your strengths, the complications and side effects of anesthesia and or sedation and what they can expect, how to reach the hospital in a 24-hour emergency, my dog is bleeding, what do I do situation. They need to observe the surgical site. They need to monitor the site at least twice daily. They need to count the sutures. Well, there were 5 in there this morning, and now there's 1. Report swelling, redness, discharge, confinement if necessary, handling of animals with Elizabethan collar or bite knot collars and the special considerations for that, scheduling appointments for rechecks, suture drain removal. No, those don't just fall out by themselves. You have to do that, and there should be a way to track those people down. And if Susie was supposed to come back or Skippy was supposed to come back on Thursday and they haven't shown up for 2 weeks, somebody needs to call them. Well, I think he pulled it out himself. No, he didn't pull it out. He just pulled one end out and the rest of it's still inside of him. Post-operative drains, client must be instructed to clean the discharge from the drain site with an appropriate substance and manner. Ensure the site is undisturbed, it's not chewed open. Soak the site to loosen a removed dried discharge. Protect skin from drying, irritation, serum scald. Clean the site, drain site adequately because it is going to be pretty yucky. Restrain patient during cleaning if necessary. Notify the clinic if the drain is pulled out, if it's broken, or if it has just mysteriously disappeared. And if it is, you may end up doing a gastrotomy to pull it out of the tummy. That's when we need those endoscopes. So handy. Care of post-operative drains. Clean the area where the drain exits the wound with a warm compress of gauze. Gauze is really good. A lot of people like their, hand towels or whatever. That's fine. Apply warm soaks to the area to soften the discharge. Don't just scrape at it. Once the discharge is soft and loose, wipe the drain area clean. Pretend it was you. Okay? Would you just want somebody to start scraping away with a Brillo pad? I don't think so. Post-operative care of patients with bandages, casts, or splints. You're going to have a set protocol at your place. You're going to follow it. You're going to do it. You're going to take care of it. But, general guidelines, keep the pet quiet, confined. Play is out for a while. Schedule weekly in-hospital checkups. If they don't show up, call them and tell them to get in. They need to check the bandage daily, as well as the extremity. Are those cold? Toes really that cold? And protect the bandage, the splint, the cast. they'll want to know, can I put a bag on it or whatever to give them a bath? You need to be able to discuss that intelligently and competently. Dental extractions, soft food diets, whatever that's going to be in your practice. Gradual return to dry food diet if that's what they're eating. What happens if there's long-term bleeding? What happens if there's indications of pain? Here's a patient relaxing at home. Now, how they're at home, I don't know, but they're at home with an unbandaged enteral feeding tube. Okay, and enteral feeding tubes, we don't do them that much, but when we do, they do require special care. Again, a lot of written instructions, a lot of specificity. Feeding tube placement, we're going to use a liquid or a therapeutic recovery diet. Administer liquid medications through this. Medication should always be given separate from the food. Okay, don't mix the two together. With enterotomies or anastomosis, gastrointestinal surgeries, we're going to keep that patient on fluid therapy until the animal is drinking and not vomiting. Feeding eventually can resume based on how you're going to handle it. I know a lot of very, very good soft tissue surgeons who really are very specific about how they handle these. And usually, if they've done all the trouble to do something this invasive and it's turned out well, they're probably going to get real unhappy if clients screw it up at home. We're going to, of course, administer prophylactic antibiotic therapy until the appropriate time, and then we will probably pick up back on it again. It just depends on the surgeon. And any of these guys can go south fast. They can really blow up on you. So they need to be monitored with great care. A lot of these guys stay in the hospital a little longer. Depends on the surgeon. But at-home care is going to have to be meticulous. Here are client operative instructions. You probably, if you do any of these, will have these. If you don't, you can use this to start your thing. A handout to give clients after GI surgeries. You can read box 10-3. Perianal surgeries, again, we have another box 10 post-operative instructions. If your practice doesn't have these, here's a great way for you to earn your keep and maybe get a little extra bonus point here and there for providing these. Cystotomy, if they go home, bladder stones out, expect them to have bloody urine for 12 to 36 hours. They will probably be on a special diet. And they'll probably be on antibiotics, probably will need frequent walks so they can keep that system flushed. If they're straining, showing pain, urination, that is, they need to let you know. And if there's no passing of urine, if they're straining and nothing's coming out, then it's okay to panic. Get them in now, if not sooner. Client instructions, following declaws. Again, we're not going to get into the ethics, non-ethics of declawing and all that kind of stuff. Here's a good start. If your practice doesn't do these, doesn't believe in them, that's fine. If they do, here's a good start again. And of course, with all declaws, the secret to success is always going to be pain control, pain control, pain control. More boxes on ear hematomas. Please go through these. You will have quiz questions and test questions on the care of patients. Okay, and most of it is just common sense, but making clients do it, that's always a challenge. Lateral ear canal resections or ablations, they're not released to the owner's care until the need for daily bandage changes passes and all drains are moved, because these are really nasty. There are so many post-surgical complications possible. It's just, there's a whole host of them. Elite e-collars are necessary to help protect the integrity of the site, and you're going to have to really be careful about analgesic medication, close observation, lots of free rechecks. A lot of people have these guys come in once a day. Orthopedic procedures, orthopedists really get into the specificity of this. You need to provide post-operative instructions specific to the procedure. Okay, not all orthopedic procedures are certainly going to be the same. You may need additional support such as a bandage, cast, non-weight bearing sling, whatever. We need to restrict exercise and even moderate activity for a specified period. Okay, whatever that's going to be and whatever your surgeon says, that's the way it's going to be. And also extensive pain management may be indicated. If you've ever had orthopedic surgeries, broken bones, that kind of stuff, you know it hurts. You really do require a lot of care. And here's a towel sling. They placed a towel under the dog's abdomen, pulled up on one or both arms. The towel sling takes some of the weight off the dog's hind end, allowing the animal to walk more easily, especially if it's a say a pelvic surgery or something with the rear legs. It makes a world of difference. C-sections, we all love our C-sections, especially when you have a live mother and a bunch of puppies. Keep the mother and newborns apart until recovery from anesthesia is complete. Okay, we don't want her flopping around going into emergency delirium and killing all her puppies. Really bad. Clients are instructed to record newborns' weight daily, see if they're thriving. Give them supplemental nourishment if necessary. Inspect the mother's incision site daily. Provide high-calorie food for the mother. Provide access to plenty of clean, fresh water because she's going to be making a lot of milk. Some of them you may need to express the mammary glands if that's needed, or provide milk or milk replacers. I've seen dogs that have had cesareans and you never know there's anything wrong. I've seen dogs that had cesareans that completely rejected the puppies simply because of the pain of nursing. With castrations, again, clipper burns and skin irritation from the surgical scrub must be avoided during the surgical prep, or these things are going to blow up on you. Then you'll be really sorry. There's going to be licking, chewing, a surgical site. They're going to end up ripping open sutures. They're going to end up with hematomas. They're going to end up with seromas. Big mess. This huge, inflamed, red, angry, terrible scrotum. The best medicine is preventative medicine, and rather than treating that, you better prevent it when you're prepping these guys. They really do need to have some degree of restrict activity for a predetermined period of time. Follow instructions. A lot of people say 3 to 5 days, 7, 10, whatever is normal for your practice is fine. And of course, our old friend space, OHEs. We can always run into skin irritation from the surgical scrub. We can, of course, need to have some degree of exercise restrictions. Pain medications should be prescribed, and we always run the risk of infections, wound dehiscence, trauma, chewing out sutures, seromas, hematomas. There's things that can go wrong. Every so often you'll end up with the internal sutures popping and you'll end up with a little hernia. So people really need to pay attention to that sort of stuff. And if all goes well, we end up with happy people, happy pets, and we end up with a happy day. And that concludes this chapter.